It's all in your head. You don't look sick. Your tests are normal. It's probably anxiety. There's nothing wrong with you. Have you heard these words from physicians, family, and friends? If you're someone who has been struggling and swirling through the revolving door of healthcare to find answers about your health, or if you know someone who is going through this experience, then this podcast is for you. Welcome to the Desperate for a Diagnosis podcast with Laura Nozicka, a show dedicated to exploring the challenges of living with undiagnosed or rare medical conditions. This podcast explores both sides of the bedside. We will be speaking with patients who have had challenges with finding a diagnosis, along with experts in the field. I'm your host, Laura Nozicka. Please note I am not a medical professional, nor am I affiliated with any healthcare, pharmaceutical, or device company. I am an entrepreneur, and I am an independent market researcher focused on helping healthcare organizations better understand the patient perspective. The podcast is not meant to offer medical advice, but to merely share the stories and perspectives of podcast guests. Hello, and welcome to the Desperate for a Diagnosis podcast. I'm your host, Laura Nozicka, and I'm excited because it's like girl coffee talk today, which I love. I have two lovely ladies on my podcast with me. I will tell you all about what they are up to and why they are here and what they are going to educate us on today, because I have a feeling that this is going to be a very educational, they all are educational, but this one is going to be doubly educational since I have both of you on the show and you have a book to prove that you've got lots of things to say and teach us today. So I'm going to welcome both of our guests, and our guests today, we have Charlene Rothkopf and Dr. Colette Edwards. And I know everyone wants to know what Z stands for, but I'll let her decide whether or not she wants to talk. And otherwise, she's Dr. Edwards to us today. And I'd like to introduce these ladies with a quick bio, and then we will get into our chat today and what we're going to talk about. And again, we've got a lot to learn from these gals about navigating the healthcare system, which is what we'll talk about today. But they both have some really interesting personal experiences that have zealed to write the book that they wrote for us today called Navigating Your Healthcare Journey, Lessons Learned to Get the Care You Need and Deserve. So that is what we'll talk about today and how we make that happen. So first of all, I'd like to introduce Charlene. She's held a variety of corporate human resource positions with a global multinational hospitality company and served as the senior human resource executive at a leading publicly held real estate development company. Following a lengthy journey as a patient navigating the healthcare system, Charlene founded the Wellness Consulting Group, which specializes in executive coaching and leadership development. She currently resides in suburban Maryland, where she enjoys playing golf with her husband of over 50 years and spending time with her grandchildren. Wow, 50 years, Charlene. So I've never been married, but my great grandma lived to 104.
Wow.
And I'm in my 50s. So I figure if I meet wonderful now, I guess I'm married for 50 years. Only you can tell me what that's like. So,
well, thank you, Laura. It's a pleasure to be with you.
Thank
the
you.
opportunity.
You are welcome. Let me tell everyone a little bit about Dr. Edwards. She is also an MBA. So I have two overachieving ladies here, no doubt, today. Dr. Edwards has been active in most segments of the healthcare arena, including first and foremost as a practicing gastroenterologist. She has leveraged additional training in health and wellness coaching at the Maryland University of Integrative Health and in health equity as a member of the NIH Scholars Program in Translational Health Disparities. Over the course of her career, she has served in a variety of roles in her quest to make a difference in the lives, health, and well-being outcomes of patients. They include being the associate medical director of a multi-specialty group practice and serving in health plan medical roles. Her work has also encompassed positions at two Fortune 50 companies, including as the National Medical Lead for Health Disparities with an initiative that won a National Innovation Award
and as a corporate medical executive for employee health and well-being with a multi-year record of national awards won by the team. She also is the managing editor of the Wharton Healthcare Quarterly, the author of Be Less Stressed, and Graw Hill GI Text, and she is a member of the board of two nonprofits, Bread for the City and T1D Exchange. Dr. Edwards, you live such a boring life. I mean, you have to be able to squeeze one or two more things in there.
Okay, I'll work on that, Laura.
Wow.
That's for
Yeah.
us.
I'm telling you, what's the T1D Exchange?
It is an organization focused on patients with diabetes 1, as opposed to diabetes type 2.
Okay. Very
And I am a member of the subcommittee that's focused on health disparities.
Got it. Well, there certainly has been, that has all been brought to light even more so since 2020. That's like a bad word, 2020, COVID year, but we certainly have learned more about health disparities even since then. So I'm so looking forward to our conversation. I'm so happy to have you here, and you have so many exciting things going on, but I think it would be really fun to talk about how the two of you met, because any more than one person on a team, especially co-authoring a book, could certainly be a challenge to find a good co-author buddy. So tell me how you ladies met.
Well, we're both graduates of the Health and Wellness Coaching Program at the Maryland University of Integrative Health. And we met there, and we were both on a panel and hit it off. And after that point, we decided to do some executive women breakfasts, and a number of them on different topics, one being the art and science of healthy aging, and authentic leadership was another one. So we when this whole the pandemic started and we were mostly working from home, I started working on this book, and I thought maybe I knew Colette would be a great resource, but maybe she'd have time to work with me on it. And so I invited Colette to join me, and that's what we worked on during the pandemic.
Yeah, wow. Yeah, that's one more thing that Dr. Edwards needed to say. What kind of book? Well, what a project, because while everyone was cleaning out closets and Marie Kondoing their lives, you ladies were busy writing a book, which so many of us always say, I have a book in me, I have a book in me, and we like to think about it, but to execute on it is a whole nother story. And I do like the idea of the art and science of healthy aging. I think you ladies will have to come back and maybe talk about it times. But yeah, so Charlene, you started writing the book, and Dr. Edwards, you get this request, or this offer, if you will, from Charlene. Hey, bestie, want to come write a book with me? What'd you think about that?
I was very interested and excited about it because I had always thought about that for, going back many, many years, but never got to it. So this was a great opportunity to just put a stake in the ground and move forward and just do it, as Nike says. So that is how we spent a lot of our time during the pandemic. And I think it was helpful during those times to be focused with passion and a mission in the midst of everything that was going on, not just in this country, but globally.
Yeah. Yeah, I think at that point we all needed a reason to get out of bed, and if there wasn't a good one, this one sure was it. And what was, Charlene, what was your initial thinking about the book's premise, and maybe how did it change as time went on, as the two of you started to collaborate?
Well, it actually started from my story. I'm happy to share that with you briefly.
Please.
Uh,
Yeah.
um, and the story, my story as a patient, I mean, I was a human resource executive and had managed health and welfare benefit plans. So I knew from an insurance point of view, but I never really understood the healthcare system as a patient until I was in it. And so in 2008, I had an offsite meeting with my team. I'll make this brief. And came home, was checking my email, and all of a sudden, my hand started to cramp. I went to show my husband, and he started to unclench my fists. And as soon as that happened, the spasm went all the way up on the left side, and I collapsed in his arms.
Oh my
And
goodness.
he's holding me with one hand and dialing 911 with the other. And when the EMTs came to the house, they were they thought I had a stroke, and they wheeled me out in a gurney to the emergency room. And at the emergency room, they did an MRI immediately, and the physician on duty said, "Well, I have good news and bad news. The good news is you have a brain tumor. The
Mm.
bad, excuse me. The good news is you don't have a stroke. The bad news is you have a brain tumor." And I I was totally shocked. I mean, I felt fine before then. I didn't know what was going on. And he says, "You have to have it out right away." So my first order of business was to find a neurosurgeon who could remove it because I couldn't wait. And I didn't want to have another seizure.
Mm.
So good news is my friends and family gave me a lot of resources. I found a connection to the chief neurosurgeon at a major teaching hospital about an hour away, and he scheduled the appointment within a week. I had the surgery, and the tumor was removed, and it was great. It went smooth. I was very happy. I had to spend the next 3 months recovering because you're not allowed to drive, and
Mhm.
my friends and family were so helpful during that time. And so after a while, towards the end of that year of 2008, I went back to the neurosurgeon. I said, "I don't know what's going on, but the top of my head where the surgical site is not healing." And he said, "Well, let's watch it." And so by the end of the year, he could see there was something going on at the surgical site. It wasn't getting better. And he referred me to a plastic surgeon. So in January of 2009, I went to see the plastic surgeon, and he went in to see what was going on. I had no idea what was happening. He said that the bone had become infected and that he had to put in a titanium plate.
Oh.
The- So after that surgery, which was not very pleasant at the end, I went home. But then within a few weeks and a month, I I thought it was opening again. You could actually look in and see the titanium plate.
Oh my gosh.
So yeah, it was weird. So I
That's
went back to him.
weird and scary all at the
It
same.
would, but I mean, some you could look down and see it, and so I went back again, and he said, "Well, let me stitch it up tighter," and he stitched it up in his office, and then I went home. This was an outpatient, and I went home, and every time I walked, I could feel the stitches coming open, and I could feel the pain of the stitches even though it was tight and struggling to open. And so I went back to him, and in April, he did a 3rd surgery and said and really stitched it tight. And then I went home after April, and I could feel it. I could feel it opening, and you could see again that it was open. And I sent him an email, and I said, "You're not going to believe this, but I think that the surgical site is opening up again." And he said, "It can't be. Just go home, relax, and take a warm bath." And
Wait, I read that in the book, and I thought, well, that is sound advice.
it was, he didn't believe me. And
I didn't know that Epsom salts in a bath will take care of an open wound on
well,
your head after brain surgery. Wow.
this is something called medical gaslighting that we talk about in the book.
Yeah.
Here many times based on either your gender or your age or your race or your ethnicity that they don't believe you. And so I was didn't know what to do. I went to some of my friends said, "Well, why don't you go to the wounds care center at a hospital nearby?" And I went there, and I went to see the plastic surgeon. And she said, "You have 3 open holes in the top of your head. You can't walk around like this. You'll get an infection." And she took a picture, and I said, "Don't send it to the plastic surgeon. Send it to the neurosurgeon and tell him." And I went back to work, and immediately he called me. He said, "You come in here right away. I want to take a look at it." And what I realized is he had no idea what had happened in the past 6 months. There was no communication between him and the plastic surgeon, even though they were in the same hospital.
Yeah, you and Dr. Edwards, I want to get your thoughts and opinions on Charlene's odyssey, which was it was quite a while as you were trying to get some type of resolution to this continuing open.
Yeah.
No, but you had said, yeah, you had said, "I had learned the neurosurgeon had been unaware of all I had been through over the past 6 months. There had been little to no communication across departments, and no one had been coordinating my care during this time. My treatment across 3 departments, neurosurgery, plastic surgery, and infectious disease, had been fragmented and disjointed. It was evident the physicians had not communicated with each other in the handling of my case." Yeah. So, Dr. Edwards, when you hear that, and given that you certainly have been in practice, what do you think when you learned from Charlene that that was the case in terms of such poor care coordination? What were your thoughts there?
So I can't say that I was surprised. It was obviously very disappointing for Charlene as a patient to be dealing with something that scary and potentially could have big implications for her health, and that it took that long. I think it's just a reflection of the fragmentation of the system that every single day becomes more and more complex. And then when you throw in technology that in theory is supposed to connect people and make things more efficient and more focused on the patient, I think that the vision is not always realized, and that sometimes the technology actually may create barriers to communication or be so time consuming that it's not used at all. And then, given broad physician shortages in this country, both primary care and specialty care, the types of interactions that used to happen in the past become more and more difficult to actually take place. I would say that in a practice like the one that I was in, it was multi-specialty group practice. We had every specialty. We had radiology, we had pathology, we had our own pharmacy, we had our own case managers, and it was a group that was very much physician led. There were co-leads, one on the business side, one on the clinical side, but very much physician led in terms of how the practice worked and how things were going to operate. That those types of issues did not really happen. I mean, no system is perfect, but having everybody, there were 2 campuses and primary care practices out in the community. And because we were operating as a group and looking at things very clinically, that it did make a difference. And there are systems that, continue to work that way. I think that that is a model in my mind that works very, very well. And what we found was that patients want to know that they have access to physicians outside of a network in case they need it. But except in certain situations, the case is that they don't really need to go outside the network if the network is um, good enough, and they typically don't go out all that often. Okay. So I think that there are models, and this is the case, I think, in medicine, where there are models of success. And So replication, or at least someone adopting and then tweaking, is not something that you see very often. And I think that in order for major change to happen, it's got to come from patients to push the system to be better for everyone, including physicians, because the current system, lends itself to major burnout, and physicians sometimes leaving practice because of it, particularly if they are relatively close to the time they planned on retiring anyway. And that kind of happened during the course of the pandemic. Ophthalmologist, my dentist, my PCP all retired. They probably would have gone another 5 years, but the pandemic just tipped them over.
Like wiped
It's
them.
a whole other layer of work.
Yeah. And I recently did a podcast episode with a neurosurgeon, and he talked a lot about burnout of the community and shortages, et cetera. So it's definitely prevalent, and it's definitely a concern when you stop and think about the aging population, and how will that be handled is probably still very much unresolved problem at this point. But Dr. Edwards, when you said was the technology that can impede the process of patient care or coordination, what were you referring to from a technology standpoint?
So, an example, I'll give you a couple of examples. One is the EMR, which has great promise and theoretically has great power. It is just that in terms of how it has been implemented, it is a major, 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 major contributor to physician burnout. And the EMRs that I have seen that have worked well for patients and for clinicians and their staff are ones that have been built by a physician who's also an IT guru, but they know how things actually work in the office.
Well, that's a dangerous combination.
Combination, if you can find that person.
Exactly. That's an egg stack, but the science experiments going on there. I can only imagine. But
so like I said, theoretically there is great promise, but I think because of the way that the systems are set up, without enough input by clinicians and the staff and, the people who are actually going to be using it, it's less than ideal. And it also means, when we bring in something like patient portals, that theoretically it should make things more efficient and people should get responses back much more quickly. It often is the case that it becomes one more thing for someone to do and one more place that a physician has to look for a task to be completed. So it's not clear to me that in many instances that not only has it not made things more efficient, I think it can become a heavy burden and contributes to burnout for the physicians, the staff, and a lot of frustration on the part of patients. And once again, the other component of it is with the portals, different systems have different portals. And if you are in one system, like Charlene was, and if she were to go to another system and those things aren't connected, even if someone were looking for everything that she had gone through, they wouldn't find it.
Yeah.
Let me talk about those portals for a minute, because I think for a lot of patients and their interaction is through the portal. And there's sort of a double-edged sword, as Colette mentioned. The good news is I can see an after visit summary. I can get lab results on them. If it's a non-urgent message, I can message my physician if in fact he or she does look at it and can't always assume that. But the downside is that they don't talk to one another. So if you're seeing, as Colette mentioned, seeing different specialists, they all have different portals. They all have different passwords that you have to remember, and they don't connect. So it's up to the patient to take charge of the communication and make sure that each one of them knows what's happening in the other, if you're dealing with a number of specialists, what's happening in the other practice, because those portals don't talk to one another.
Right. Because
Yeah.
there's care everywhere, but care everywhere doesn't cover off
And you need,
where you've had it. Yeah.
yeah, and you need somebody to quarterback. You need somebody, and hope sometimes it's the primary care physician, sometimes it's not, to coordinate all of the care that you're getting. And so that's back to the neurosurgeon example. That's who I thought should have been the quarterback, but it was up to me to make sure. I can't assume that one physician or one practitioner knows what the other is doing. So it's up to the patient to make sure that the communication is there.
Right. So here you are at a point where you're realizing that your neurosurgeon had no idea what was going on. So after that, what was next steps for you?
This is the interesting part, is that he called in the chief of reconstructive surgery, who was wonderful. He was actually about to retire. And he said, I know exactly what's going on. You do not have an infection. In fact, and by the way, I was on mega doses of antibiotics all this time. He says, you're rejecting the plate. He said, but what I'm going to tell you is you're not going to like. I'm going to do one more surgery in July of 2009 to take out the plate that you have. And you're going to have to wear a protective helmet so you don't bump your head on anything, because you have no bone and no plate. And then you have to come back in 6 months after your bone is healed, and I'll put in a new plate. And so my first reaction is, how do I know the second plate will hold? And he said, trust me, I've been doing this, I know. And then I said, well, I have to go to work every day. How do I wear a football helmet to work? And a wonderful nurse was so helpful. And she said, would you be willing to wear a baseball cap? I said, yeah. And she said, here's a plastic insert to put inside. And for 6 months, I wore a baseball cap to the office.
Oh
And
my gosh.
meetings. And it worked out all right.
Look
Yeah,
at you making a fashion statement. I mean, did you at least have fun with that? Like,
Oh yeah, we had lots of jokes about it, and even when we go into a restaurant or something, they'd say, you have to take your hat off in the restaurant. I said, no, I can't. So we had lots of jokes about it, but it worked out okay. And the last fifth surgery was successful, and I was able. And then by that point, I said, you know what, life is telling me something. I'm gonna retire early. And that's when I decided to go to the Maryland University of Integrative Health and start my own business.
Yeah, interesting. Why integrative health? And for both of you, but Charlene first, why, so here you are in corporate America, which I get. I've been there myself. And 7 years ago, I said, no, thank you. And went out on my own as a independent market researcher. But so I get you there. But since you were in HR and you were handling health and wellness, et cetera, from an OC health or occupational health or, wellness, employee wellness standpoint, but why integrative?
While I was recuperating from all the surgeries, of course, I was very anxious and very nervous about all these surgeries. And I found some alternative therapies. One was called tapping. It's also called, if you've heard of that, to help.
I actually had a guest who talked about tapping.
Oh, fabulous. And I also did some zero balancing, which is you're fully clothed, but it's a way of putting there's certain pressure points in your body. So while I'm very much supportive of Western medicine, there's a lot that we don't know. It's both an art and a science. And that there are other alternatives and other therapies that can be very effective. And so the practitioner that did the zero balancing actually introduced me to the Maryland University of Integrative Health, and it was exactly what I needed at the time. And so, and I guess Colette can tell you about her journey there, but it was really, it opened my eyes that there's a lot of other things that we don't know. And from Eastern medicine, there's a lot we can learn.
Yeah, yeah, for sure. Um, I've been reading more about the blue zones. Uh,
Hmm.
He's familiar with that. And I read the book like, I don't know, 10, 15 years ago.
Hmm.
And now Dan Buettner, I think is his name. He's back at it and has
Yes.
updated. There's a new blue zone in Singapore, I think. And he talks so much about food and and whatnot, and why the Western diet is so different than other countries and parts of the world, and people are living longer, which is why I love the idea of the healthy aging idea too. But just from a non-Western medicine, non-traditional medicine standpoint, I agree. There's so much to learn from a integrative standpoint, or alternative, whatever you want to call it. Some people call it the woo-woo, whatever you want. But I think in combination, the woo-woo and Western can work. Uh, Dr. Edwards, what do you think? What drew you to the integrative program?
So I think that I have always been open to lots of things and have recognized that just because things have always been done a particular way doesn't mean that there aren't other ways to get things done. And sometimes they are even more effective and less expensive. My father started off in general practice and then he went back and trained in anesthesia. And really, back when no one in this country, I think, except maybe in some pockets in Berkeley, he actually did some training in acupuncture. So I always had kind of that influence of looking outside of what's possible. He was a voracious reader. And um, long before people were thinking about how to eat and what supplements they might need, he was investigating all of that. So I was actually going to get acupuncture treatments. And there was a banner in the lobby that talked about the launch of this program. So I was in the inaugural year. Charlene was in the year after me. And I looked at that as because at this time I was no longer in direct patient care. And I looked at this, wanting to go back at some point in time and having that interaction because there's really nothing like patient physician relationship. I mean, people will tell you things they won't tell anyone else. So it really is an honor and a privilege. Because my specialty is GI, I recognized that going back at some point in terms of seeing patients and doing procedures was going to be unlikely just for practical reasons from the standpoint of, um, refresher in terms of doing the procedures and having someone shadow me for a while to meet, credentialing criteria for a hospital system, for example. And it became clear to me that a lot of what the issues are for individuals everywhere, but particularly in this country, are areas where people actually do have some control because it has to do with their lifestyle. And some component of not living a healthy lifestyle as much as we should is things that people don't know. But for a lot of people, they do know, but the motivation just is not there. And the system is set up in a way that makes it easy not to proceed along the healthy path. And so I felt that in terms of coaching, where you are really helping someone develop confidence in themselves, see possibilities, recognize the power that they have to take control, that in a way that could be as powerful, if not more powerful in some ways than direct patient care, and certainly contributory to people being healthy. And it would be a way to get that one-on-one interaction without having to do the retraining, et cetera. So that's kind of how I looked at it. And at that time I had a lot going on, as you might imagine. And I said to myself, taking on this course, it's either going to be one of those situations where you're really engaged and energized, or it's going to totally deplete you and you're going to go down in flames. And thankfully, it was the former in terms of being really energized. And a lot of what I was reading at the time when I looked at the curriculum were a lot of the areas that I was already reading about. So I said, well, I'm already kind of doing this on my own. I can go through with people who are experts in this, have done the curation, et cetera. So that's how I ended up in the program.
Yeah, I think that it's definitely becoming more uh accepted, I guess I would say, in a lot of ways. Like I said, a lot of the guests that I've had on and still have recordings to edit and drop have talked a lot about the more alternative modalities that have helped them. A couple of ladies wrote books and now have their own coaching businesses because they had autoimmune diseases, lupus, rheumatoid arthritis, etc. Certainly, like Crohn's, colitis, autoimmune in that aspect as well. But yeah, it seems to be becoming more accepted and certainly intertwined with traditional medicine. But I want to go back to the technology for just a second, and I'm probably not the only one that this drives me crazy. And I think there's a law that's driving this, but Dr. Edwards, you might be able to speak to this better. When lab results get pushed out to patients before physicians see them and interpret them for the patient, and now the patient, including myself, and I see something that might be a little out of range, and now, thank you, Dr. Google, I'm trying to figure out, well, what does this value mean? And why is it out of range? And what does it mean when it's too low or too high? What what can you say about that? And what could you either say to help patients kind of quell their fears when they're getting something that, it could very well be earth shattering for them, and yet it could be something incredibly benign, and we're getting ourselves all worked up and anxious about these test results that most of us don't really understand or know how to. Any thoughts around that?
So I think it really comes down to the person, their health beliefs, and how they want things to unfold for themselves. There have been studies that have said that high percentages of people, particularly if you're looking millennial, Gen Z, they would much rather just know and do some research. And if the price of doing that kind of out of context is a freak out moment for them, it is worth it.
Yeah.
Other people, I think it's a decision. It's there, but you don't have to go in and you don't have to look at it. And then you can have that conversation within the context of a conversation with your physician, and then follow up in terms of this means XYZ. And now the next steps that I would recommend are ABC. So I think it really comes down to how a person's personality and what their preferences are. It can be um, a not great situation in the case of someone who personality probably is to wait and hear it from the doctor or the nurse practitioner or the PA within context, but their curiosity gets the better of them because then they see a number that looks very scary. The physician, the labs are posted from the lab. So the physician may or may not have seen them already. And so the physician then is getting calls from a freaked out patient about lab results that they have not even seen,
Mm.
as opposed to it used to be more the case that the labs would come, the physician would review it, they would initial it, et cetera, thinking back to kind of the paper chart scenario.
Right.
Um, but all technology can be good, it can be bad, and it can be good for some people and not so great for others. And so, that's kind of what I would say. I think it's also important to kind of find out how the clinician typically operates and to tell you that the labs may become available before I've seen it, because you aren't in that moment. If you have a lab result that's freaking you out, you aren't thinking about how the system actually works. And so I could easily see a patient saying, well, how can you not know I'm dying? But for the physician to kind of set expectations of how things actually work, and that it could be the case that you will see something, I will not have seen it. And they can say that, it's going to be up to you whether or not you go and look. But in my experience, XYZ. And that's going to depend, obviously, on the patient population that they're seeing.
It actually came up in one of the patient and family advisory council meetings that I was part of. And I'm not Gen Z or millennial, but I prefer to get the lab results as soon as they're available, because I have a chance to look them over, and I have a chance then to prepare my questions that I'm going to ask the doctor about when the doctor calls me. And sometimes the doctors don't get back to you for a day or two. And so it gives me a chance to digest them, to do my own research and figure out what I want to ask. Other people, like Colette said, will freak out by reading them and imagine the worst. And so it really is a personal preference thing. I think that's actually one of the things I like about the portal, is that I can get access to those, and I can see over time how they've changed, and it's all right there in front of me. So I kind of like that, but I'm not like everybody.
Yeah, because even with people who have been seeking a diagnosis for a long time, and Charlene, with you, it wasn't necessarily a diagnosis you were looking for, but you were looking for some type of resolution to this open surgical wound that wasn't healing. And whoever knew you'd have a reaction to the titania, right? Dr. Edwards, you had said in the book, as a physician in practice, I was always surprised when a patient who had been seeking a diagnosis for quite some time before being referred to me would express shock and then relief when I said, it doesn't make sense medically and I can't explain it. But since you say it is happening, we need to move forward and figure out what is going on and what can be done about it. Which I think is unlike, I think, what a lot of patients do hear from their physicians, that you acknowledge that there is something going on, and if it's pain or whatever it might be, it's their pain. It's all relative, of course. What do you think impedes physicians from pushing and persevering and trying to help patients get a diagnosis, and the fact that you're willing to say it doesn't make sense, I think, is very honorable to admit. I don't know. I mean, some patients would rather hear from their physicians, I don't know, but let's figure it out, versus some of those other things that patients hear because of, like we said earlier, Charlene, the the gaslighting or patient profiling. It's all in your head, etc. All those things that I say in my trailer. But what do you think about that as to why physicians maybe don't go that extra mile?
So I think that there are probably a lot of factors. In my particular case, strong influence on me in terms of how I thought about things and approached things from my father, who was a much beloved physician. And I think that I don't want to make any blank statements, but I think that many people find that women do more listening. And I have always maintained, I learned pretty early, like in residency, that if are just quiet and you listen, that a high percentage of the time, the patient will tell you what they have. They won't tell you as a diagnosis, but they will give you enough information to either increase the likelihood that you will know what the diagnosis is or point you in at least a starting point for something that's not clear of pathways to take. And so I learned that lesson early. I think some of that was, I feel like I got excellent training, both in medical school, residency, and fellowship. And I think part of it is just kind of the person that I am. I've never been a person who has felt that I need to pretend that I know something that I don't know, because pretending doesn't get anybody anywhere. It just ends up not helping someone, or it just delays the process and it's going to frustrate someone who's already frustrated. And I am, in my own personal experience, there usually is an explanation. You'll sometimes be in a situation where it's, something that's called idiopathic, which means we don't really know. But a high percentage of the time, it's going to be the case. It might be something that is less common, or it may be that the symptoms are uncommon for something that is common. But, time, patience, curiosity, are really, really important in taking care of patients. I think that, once again, the system as it currently is structured is not well designed to give patients, staff, clinicians the time to think that would be optimal. And, in any situation, there are going to be a few people who their personality is very different than what I described. And then there are, clinicians are people too. And so biases come into place. It's very common that some of the experiences that women have when they present with the complaint are experiences that men would not have. And if you are a person of color, that may be further compounded. So it's a complicated situation. I always say that, every system is designed perfectly to give us the results that we get. So I always go back to the importance of patients knowing as much as they can, taking as good care of themselves as they can, and advocating for themselves and asking questions and pushing the system, because unless patients push the system, the things that need to change for everybody in the system, both on the patient side as well as the staff, as well as clinicians, is not going to happen, because there's so many other forces that are in play that have resulted in the issues that we face every day.
Laura, there's so many time constraints on a lot of physicians.
Sure.
That are under pressure to see a lot of patients in a short amount of time. And, I recall this quote that we have in the book. It's by Sir William Osler, who was considered the father of modern medicine, who said, "The good physician treats the disease. The great physician treats the patient with the disease." And so a lot of it has to do with the communication and finding out what's really important to the patient and finding out as much as you can, and for the patient to come forward with being willing to share that information. And the communication is the key, because as Colette said, the patient will almost tell you what the problem is, and let them talk and listen. And I have a wonderful rheumatologist who says at the end of it, he says, "What else do I need to know about you in order to find the best possible care?"
Wow.
And
Wow.
he's a great listener, and he really wants to know what's important to me, what, not just my family history or medical background, but wants to know what's important to me, and what would be a great way that I would be feeling comfortable sharing information with them. It's fabulous.
That's wonderful. Um, Dr. Edwards, when you say patients need to push the system, what would be an example of that? And how do physicians overall react to that? How do they accept that or not? Um,
So I think
things we don't hear on the other side of the conversation. Yeah, what do doctors say about that?
though I think that Charlene is kind of an example of someone who is learning as much as she can, is prepared for that appointment, knows what her priorities are and her concerns are so that she can get the most out of the appointment. I would say that in terms of the reaction that physicians have, once again, it's going to come down to the person and their self confidence and their training and their philosophy. I mean, it was very common where I would have patients coming in literally with reams of stuff that they had printed off the internet and ask me, what did I think? And I would say, I don't know what I think because I wasn't aware of that study or I haven't read it yet, but I'm more than happy to take your information and get back to you. I think that there are some people, once again, physicians come in all types and flavors. There are some people who, are still from a mindset of, I know all and I will tell you what you need to do and I don't need any help from you, etc. I think that that is less the case as time has gone on, but it's still present enough to cause a lot of people issues in the system, given that sooner or later, unless you are way off the grid, you're going to interface with the healthcare system, whether you want to or not.
One of the ways to push the system is to ask for a second opinion, and that's not easy to do for a number of folks. I was with he was the chief of rheumatology for a well-known hospital, and I was concerned that he wanted to up my medication. And I said, you know what? I really think I need to get a second opinion. And he said to me, um, there can be only one captain of the ship.
Hmm.
And I, I never went back to see him again after that, but I went to get another opinion. And in fact, the other opinion, the second person I saw actually wanted me to reduce my medication instead of increasing it. So I think one of the things you can do if you're not sure, and it's hard because you don't want to offend the doctor, you don't want them to think that you don't trust them, or it may be that you just don't understand. But if you're feeling uncomfortable or you're not sure or suspicious that you're doing the right thing, it's very normal to ask for a second opinion, but it's not always easy. So that's one way to push the system.
Yeah, I get that because my dad passed away at the end of January, and he had CHF and type 2 diabetes, and eventually his kidneys weren't doing so well. When he passed away, he had stage 3 kidney. But I had said to him, well, Dad, I'd really like it if you would get a second opinion on what's next for you. I'd like you to see a nephrologist. And my dad was a brilliant CPA, so he certainly was not a dumb guy by any means. But he said, oh, I don't know if I could do that because, all these guys, they talk to each other. And if they find out that I'm talking to another physician, they might be upset and may not give me as much attention as they have in the past. And I thought, who are you? I had this dad who was like, you didn't want to duke it out with him in a negotiation because you would lose. You didn't want to have a political conversation because you would lose. You would just lose. But here, the idea of potentially offending a physician was kind of coward him, and I'm sure he's not the only one that would feel that way. So to your point, not wanting to offend a physician, it's hard to push for a second opinion, and it takes time too. Sometimes you can always get in to see another specialist, etc. And I also had a a guest on the podcast who was having a lot of issues with potentially long COVID, maybe some other related things like POTS or some of those other things that are nebulous things are sort of coming along because of COVID or coming out because of COVID. And she said she'd been looking for a diagnosis and help for a really long time. And she said, I got dressed. I looked really nice. I had all my questions laid out for this doctor. And when I got there, I just lost it all. I lost my confidence. I lost my train of thought. So what do you think all that's about?
A lot of it, you're out of your element. It has nothing to do with your intelligence or your level of education. You're out of your element. I mean, you're talking about a lot of medical jargon that you don't understand, a lot of equipment or tests that you're nervous about. And when people are anxious or nervous or out of their element and they can't really, um, you know, they don't feel confident in being able to question the doctor or to pursue that. And I understand it. I understand it. We've been through it, and and it's a reality. And I think the best thing for us to do is to do your homework for sure and come in prepared. But sometimes you have to bring another person with you to be able to do that. And we have some stories in the book where their friend or partner comes in and takes notes and can actually be their advocate for them when they're nervous because you're going through it and you're anxious, right?
Charlene, that's great advice because and not everybody has someone to bring with them, unfortunately. But what did you learn about advocating for yourself through your situation, your journey?
Um, I learned not to give up. I learned to persevere. Um, I'm I'm appealing a case right now with an insurance company who denied a claim that I know should be covered, but you know, that's part of it is to use your resources. And I learned about how hospitals work. And I learned there's a patient relations person that might be able to intervene for me. And there's other resources in the community that I wasn't aware of before. And so I've learned to not give up. And I've learned to absolutely, I have utmost respect for the medical profession and for everybody I'm dealing with. And I want to be sensitive to their needs as well, because they're human. And I don't want to be rude. I don't want to be obnoxious because you know what? They're human and they're going to react differently to me if I don't act. I like to say I want to be politely assertive. Is
I
my
like that. That's a good term. I have
good attitude.
heard that.
And I've just learned there's more resources out there, and by doing and absolutely by doing this book with Colette, I've learned so much about what's available to folks, and to rely on each other, and to rely on my friends and resources and family members because they all have gifts that they can, and I appreciate it. So
And we've all been through as we get older. The fact is, we all will have experiences in the healthcare system, whether it's personally or with family. And there's me personally, I've worked in a lot of the healthcare systems here in Chicago in a marketing capacity, but it certainly has exposed me to all kinds of things. But even for myself, knowing what I know about the healthcare system and all the market research I've done in healthcare, there's still things that are just mind blowing and confusing from the way the bills come and they're not itemized and you have no idea what the bills mean and the codes and how it all works. I can't imagine what it's like for someone who just doesn't have that point of reference at all.
yeah, unfortunately, people can be alone, and they, um, I've learned as I've been talking to people, it's okay to share your experiences because they tell you yours. And I know when I speak to a physician, I'm not afraid to tell them some of my fears or some of my background that might be embarrassing. I have a friend who didn't want to tell the physician that she was taking an antidepressant because she didn't want the person to know. And I said, you have to tell.
Yeah.
I think being able to share and be willing to be vulnerable and share what they need, because they need to know that. And so just like with all the medications, if you don't tell your physician, even some of the supplements you're taking, that can harm you if there's some adverse reaction to some of the medications.
For
And
sure.
and to question, do I really need this? Is there another alternative? What would you do if this were a member of your family? What would you recommend to them? And so there's a lot of questions to ask before you absolutely just blindly go into doing whatever is told. But it's not in a adversarial way at all. It's
Sure, for
more be curious and try to take it all in.
For sure. So, Dr. Edwards, going back to Charlene asks you if you'd like to collaborate on a book. Tell us about how the book, because there's so many great stories that I'm sure other people, I'll say people, we're all patients at some point. So I always kind of toggle between, do I talk about people with a particular condition or do I talk about patients? I always have a little internal conflict about that. But you have so many amazing stories that are examples of some of the things that we've talked about. And then you have great takeaways and what you need to know and advice. Tell me about how the book is organized and what people could expect to learn from the book.
Well, each chapter does begin with a story, as you said, and following the story are some lessons learned, either lessons that the person learned and communicated, or lessons about how things could have gone differently if they had proceeded in a different way or acted at a different point in time. And then the chapter proceeds on the topic at hand. So in a chapter about mental health, it involved a mother and her daughter and their journey. And so then we talk about mental health conditions and the stigma that is involved and resources that are out there. And then all of the chapters end with actions that people can take right away. And then there are additional resources at the back of the book on each given topic by chapter.
It's great because there's so it's so complicated, as we know, the healthcare system and the topics that you have here apply to so many from the standpoint of taking charge and embracing a healthier lifestyle, choosing the type of doctor you need. Certainly, Charlene, you had talked about that in your story that, and luckily it sounded like you had enough time to evaluate neurosurgeons and kind of interview them before you pursued your procedure. And I think in your story too, you were asking about staffing and shortages and what kind of aftercare you would have when you were in that inpatient phase of your procedure. And I think just trying to figure out what works for you if you have time, that's so critical to where things go for you thereafter.
Yeah, I want to make sure that it's clear to the listeners that we don't give medical advice in this book. Okay, we don't mention any specific practitioners' names. We don't mention any facilities. That's not what we're here to do, but just to help guide people to ask the right questions and to figure out what they need to do when you're under enormous stress and anxiety. And that's the key is how do you keep yourself? We have a chapter on your emotional well-being and how do you maintain your emotional health when you're going through 5 surgeries? How do you do it? or it's a life and death situation. How do you get through it? And so we give people some thoughts and some ideas and some guidance on how to go about it, but we certainly can't provide any definitive answers for them. So that's what we're trying to do here is to help people through their journey because everybody's different and every situation's different. So
And I think that some of the major benefits are the stories uh, are ones that people can relate to. And it also makes it clear that you aren't the only one in a particular situation, because I think it sometimes can become easy to think that you're the only one. So you already don't feel well, and then you feel like you're alone. But the stories make it clear that we all have struggles at some point in time, and sometimes they involve the healthcare system. I think the other thing that was quite clear from the people who uh, were gracious enough to share their stories was a drive on their part to help others and help others avoid some of the things that they had gone through themselves, and to share things that they had learned for the future that could make it better for other people.
Yeah, that was really the motivation for a lot of folks to share the stories, because we had to get them to sign off on it and make sure they were, in some cases, we changed the names, but they thought, I want to help other people. I want to share this story so they will benefit. There's no reimbursement for them, but there's a way of sharing their story so that they can learn from their experiences.
Well, there's so many, especially in those situations that are overwhelming, like yours, Charlene, or some of the other stories out there, or the experiences that we've had personally, that your mind is just in so many places you can't possibly think of everything. So if there's even just one thing out of the stories that somebody would pick up to say, oh, I didn't think about having to ask that question, or make sure my mom gets the right care from a home health discharge standpoint, and how do I get a this, or get, any of those things, because there's just so much to understand. Top it off with, as you have here, paying for health care. That's a whole nother topic in and of itself. But Dr. Edwards, I know you wanted to talk a little bit about health disparities. We started talking about it a little bit, but tell us some of your thoughts on that, and some of the things you'd like to bring to the forefront here.
So, health disparities are differences that you see in either the types of conditions and issues that certain groups of people tend to experience more than others, or health care treatment or lack thereof that they may experience for reasons of bias, racism, sexism, homophobia. Um, and I think it's important for people to be aware, number one, that they exist. It's important for people to be aware for, particular groups that they are in, how symptoms may be different than for others. So for women, for example, when it comes to heart attacks, everyone thinks of the arm pain that goes into the jaw, et cetera, elephant on the chest, which is still the most common presentation, both women and men. But women also have other symptoms, and may not necessarily have those particular symptoms, like extreme fatigue, nausea, um, and symptoms that can become attributed when they go to the emergency room to a GI problem. So, with that knowledge, you're in a better position to say, I think it could be a heart attack, and to kind of insist for it to be proven otherwise, right? Because in the emergency room, the idea is you make sure someone has something that isn't going to kill them, and that they are safe to go home, or they need to be hospitalized. So just knowing, first of all, that those symptoms may be different. And when you have them, like, it actually could be happening to you. I mean, I have a friend who had a heart attack at a very early age, and she didn't recognize the signs. And um, there was a delay in treatment. So knowing things like that, I think that it's also the case that people experience differences that then lead to medical gaslighting, and medical gaslighting then exacerbates the health disparities when in the system, if the people who you're interacting with make certain assumptions about you, like how much you know, what you can afford, what you'll be able to do without asking you, and making assumptions that someone is saying that they are in pain and they think that it's just drug seeking behavior, but they really are in insufficient pain to warrant it. No, it's common in an emergency room situation when you look at large populations of Black patients or brown persons of color who have pain, for it to be poo pooed and for people to be denied um, opioids or stronger pain medications when it's really warranted versus being sent home with some Tylenol or aspirin, which is probably not going to work well for um, a broken bone and, the bone is sticking out of your skin. But fortunately, those things happen. The same thing you see when it comes to the maternity area. And, Serena Williams is a great example where she was well known, she was wealthy, she's a smart cookie, and she had had a previous history of having had blood clots, and she knew something wasn't right. There was hours of delay, and still people were not listening to her. So, I mean, that's kind of an example of how difficult it can be, and you can understand how people then don't have the courage necessarily to push, or they start to push and they get a response that kind of smacks them down. But I just say, recognize, with me knowing everything that I know from taking care of patients as well as being in the broader system with, my parents in the hospital, there have been times where it has been one thing after the other, after the other, after the other, and a struggle and the care coordination and all of that. So for people to recognize that it's hard for everybody, and therefore they just need to push to what it is that they need to get the care that they need and to optimize their health. And to also think about, in a different situation, like buying a car or buying a house, how much homework they do. They need to be doing at least that much homework when it comes to their health and healthcare. And, one of the examples that I always give of kind of how I would love um, people and patients to be when they are in the system is parents of children with rare diseases or cancer, because those fears, all of that kind of falls away because they are fighting for their child. They will do research to the point that often they know as much or more than, the studies that may be going on globally for that particular condition. They will ask those questions and they will keep asking the questions until they get answers. If they don't understand, they'll keep asking questions until they understand because they're fighting for their child. Now, they may not even necessarily do it for themselves, but if all of us went into it with more of that approach, then I think the system would change.
Yeah, that's a great way to put it. So the research that we do for a big purchase, et cetera, a car, whatnot, is a great way to think about it. But healthcare is also one of those things, few things that isn't returnable or refundable, is what I like to say. If it doesn't work, you don't get your money back. There's no 60-day guarantee.
Yeah, on average, that is not true, but actually there is a health system, and this was years ago. And it's a health system that is known for being innovative, but they actually took a stance for certain procedures that, in terms of the clinical outcomes, in terms of the cost, in terms of the patient experience, if none of those came through. So let's say if the patient had a complaint and they just weren't happy, that the patient would get any money that the patient had to pay, that they would actually get it back. And it turned out to be the case that they didn't have to do it very often. So I think that, for an organization to take that stance, you've got to believe that they are doing some pretty amazing things in a very efficient, high quality way. And they've got the customer, patient, consumer experience approach well embedded in the culture. But, um, um, and I would say that when I was in practice, we would have a voucher that patients could then use for a future visit if we kept patients waiting beyond a certain amount of time.
Wow. I love
And most of the time, occasionally a patient would take a voucher, but most of the time the patients would not take it. They would say, I know that meant that you got caught up and you had to spend that extra time with someone else. And if I'm in that situation, then I want you to be doing that same thing for me.
Yeah. What happens if a patient is running late?
That happens too. And so they try to fit them in, or they try to, if it's really late, they'll try to reschedule it. But there's, there's an implication that there's other people there too. So if they can work them in, that's fine. I was just thinking, Colette's triggered something in my mind. My husband's a dentist, so I don't want people to forget about their dental care as well as their medical care, because many times they're related. And if somebody's really unhappy with the work that was done, you know, I told my husband will refund their money and tell them that's because, not all the time, or we'll say just cover the lab bill or whatever. But it's really important to make sure that you're doing what the patient feels good about and feels satisfied as well, and that you're working with them as in a partnership. And I think that's the key to a good relationship, whether it's a physician or any kind of health practitioner or a dentist, that you're really in a partnership with them.
Interesting. Yeah, I had not known that that there are some practices out there. Now I'm sure things like heart surgeries and titanium plates, when they don't work, you, you're
Yes.
there's no money back guarantee. Then luckily it all worked out, and they kept pursuing solutions for you. So yeah. Um, Charlene, something else I know that you felt really passionate about wanting to address today is end of life.
Yeah.
And unfortunately, we will all get to that point in time with loved ones and making decisions even for ourselves as that comes. What are some of the things that are important to you that you'd like to bring to light here and help people through? Because it is so hard. It's so hard.
It is very hard, and it's very difficult to even talk about it with family members, knowing that might be imminent, and to have those conversations. But the key is to be prepared in advance, and to have an updated will and updated advance directive, and with someone with a power of attorney to make decisions for you if you're unable, and to have that. In fact, many times when you go into the hospital, you need to show them your advance directive so they know what to do. Um, and if you can and can afford it, to have some think about long-term care early on, so that if you need assisted living or what, and know the terms of that long-term care. I have a neighbor whose husband is in an assisted living facility, and it doesn't cover everything there because he's still able to do some things on his own. So know what the terms are, and it's the younger you do this, the less expensive it can be. Um, I think it's important to know even things like where are all the bank accounts, where are all the passwords, where are all the documents that you need. I'll be honest with you, a lot of people don't know this, and so you need to write them down. You need to know where everything is, especially with dealing with people at the end of life. They're often on a lot of different medications, and to know where the medications are and how much they're supposed to be taking and what they look like, and should they still be on all of them, and to coordinate that care at the end of life. Um, Finally, there's a couple of resources that we really should know about. One is palliative care, which is not just limited to end of life. If you're in a lot of pain, if you're in cancer treatment, how to use palliative care resources to help you manage through that.
Which is not hospice. It's
It's
different.
not hospice, and then hospice care, if it truly is, there's no more treatment that can be done, and it's really to make the patient feel comfortable in the last days of their lives, so they can at least be home and be surrounded by their loved ones. So there's a lot of things, and we have a story in there of a woman, and her mother was 105, and how she handled that, and she was not in the same city. I mean, she was remote, and how she handled that whole events and turn of events. So unfortunately, we're all going to go through that, and the best thing you can do is be prepared.
Yeah, we just went through it with my dad's passing. And again, he was a brilliant CPA, but these are just things that are very, as you said, difficult to talk about. And very coincidentally, 2 days before my dad passed away, and it was a sudden, unexpected passing. 2 days before that, we had an attorney at their house talking about updating the will and trust and all these things. And my parents aren't super old, but they're in their early 70s, and just not something that they wanted to talk about. And I get it. Nobody wants to, but it's something that even for the whole family, me, for instance, I'm an only child. So I need to know what's going on and what's happening. And we didn't have the password. So all I'll say is that if I needed a second job, I could probably figure out how to get into a computer. Let's just put it that way.
Well, it's tough. It's a tough thing, but it really is important. So I'm sorry you had to go through that, but we all do. It's something.
Well, resilience and the whole whatever doesn't kill you makes you stronger, and I believe in it. Believe that. And for you ladies, you may, as you've heard the term, make your mess your message, and that's what you've done here with the book. Any other key points that you'd like to make about what's in the book or what folks can get from the book? And then you can tell us where we can find the book. And again, the name of the book is Navigating Your Healthcare Journey: Lessons Learned to Get the Care You Need and Deserve, co-authored by both of these lovely gals. But any other final points here and where folks find the book?
And I was just going to suggest that if people want to learn more about what's in the book, they can go to our website, which is navigatingyourhealthcarejourney.com, and read about what's in there and sort of the messages of the book. And there's also some resources that I think would be very helpful. There's a list you can download of 20 questions to ask your doctor. So there's some good resources there, I think. Colette, anything else?
I would just say for people to have confidence in themselves, because no one is ever going to be in their body. No one's ever going to be in their mind. They really are the CEO of their health and well-being, and to trust their gut and to keep pushing when necessary to get the care they need and deserve.
Right. And is the book on
It's on Amazon
as well?
Barnes and Noble and bookshop.org. So they can order it a number of places.
Perfect. Well, we will have all of those resources and where folks can buy the book in the show notes. But I'd like to thank you ladies for being with me today. Highly enjoyable conversation, and so much I know I learned from you both, and hopefully the folks listening will learn a lot too, and also pick up the book. So thank you to you both. This is another episode of the Desperate for a Diagnosis podcast. I'm Laura Nozicka. Thanks for joining, and stay well.
Thank you so much.
Thank you, Laura.
Thank you.
Oh my goodness, that's a wrap on another compelling story. Thanks for listening to the Desperate for a Diagnosis podcast. If you would like more information about today's guests or to find out more about Laura, me, go to desperateforadiagnosis.com. If you enjoyed the show, please subscribe, rate, and review the podcast on Apple Podcasts, Spotify, YouTube, or wherever you get your podcasts. You can also follow show updates and healthcare news on the podcast's Facebook page. If you would like to be a guest on the show, or if you have any questions, advice, or suggestions for our guests, please email me at lauramarie@desperateforadiagnosis.com.